Next is our colleague from CDC, Dr. Kevin Horton, who's here to talk about the science of the ALS Registry.
Good morning. So I would also like to thank the ALS Association for inviting us here again. This is one of the conferences. You know, we in the CDC go to a lot of conferences a year, and this is by far one of my favorite ones because we get to interact with scientists, with patients, with family members, and it's really a pleasure for us to be here to talk about what it is that we're doing and to kind of give you an idea of which way we're heading. And, you know, you mentioned about the Hill tomorrow. Hopefully, what we cover today will kind of give you some ideas of at least what we're doing. I'm here today with a couple of my colleagues, Dr. Paul Maida's over here and Tom Hicks, and we have our booth right out front here. So if there are any questions that you have, by all means, feel free to stop by and ask any questions. So today I'm going to talk about what have we learned from the registry. So you've seen me stand up here year after year talking about the registry. We're finally getting to a point now where we're starting to generate data from the cases that we're capturing and identifying around the country. And I'll talk about what some of these findings are and, like I said, which way we're going to be going in the future. We've got something that I think is very exciting. But first of all, and I apologize, many of you have seen these slides before, but there are people probably here in the audience that may not know what the methodology is for the registry, but I think it's important for everyone here to understand how we identify ALS cases around the country. So as you're aware, the ALS Registry Act was implemented and passed in October 2008. And essentially this directed the CDC ATSDR to create a population-based registry for the entire U.S. And so we launched the registry in October of 2010. It took us a couple years to pilot test methodologies for us in between 2008 to 2010. ALS is not a reportable disease, and so we had to come up with some novel approaches for how do we identify and track cases of ALS around the country. So it was launched in 2010. And if you can go to our webpage, and the actual bill, the language is on there. But if you look at it carefully, it asks us to do a couple different things to describe the incidence and prevalence of ALS. So essentially, how common is this disease? That's a way you get a handle on a disease. You need to know what it is you're dealing with and how many cases are out there. Who gets the disease? Is a question that we're trying to answer. And then was brought up a few minutes ago, what causes ALS? I mean, that's the big question that we're all trying to figure out here. Why do you have ALS? And so I'll tell you a little bit about what we're doing to try to answer that question. And I mentioned that ALS is not a notifiable disease. I think it's important to state that there are thousands of diseases out there that are not notifiable disease. ALS is one, Parkinson's, Alzheimer's. So it's not just that, you know, the federal government doesn't care about ALS. There's a lot of different diseases out there that are not notifiable. And so that makes it more challenging for us as a registry to come up with strategies for how do we track and identify these cases. So we take a two-pronged approach for identifying cases. On your left-hand side, we use large national databases such as Medicare and Medicaid, the Veterans Health Administration database, the Veterans Benefits Administration database. These are large federal databases that we can use to identify cases of ALS. And what we do is we apply an algorithm to these databases, And in the algorithms, things like ICD code, which is a billing code or a diagnostic code for ALS. Is a person on Rilutec or Riluzole? How frequently do they go to a neurologist? And this is a way that we're able to identify new cases. And so those that are true ALS cases will be put into the registry. And on this approach, patients don't have to do anything. This is something that we're handling at CDC ATSDR. On the right-hand side is the approach that I think all of you or most of you are familiar with. This is our web-based approach. And so we're asking that patients with ALS come to our website, www.cdc.gov/ALS, and enroll in the registry. And essentially, you answer a couple of validation questions, and depending upon the way you answer these questions, you'll either be put into the registry or you won't. And so whether a person thinks that they are in the registry through the national approach, we still want everyone with ALS to come and enroll through the web portal. And this is important for a number of different reasons. The national database approach, some of the data, especially from Medicaid, there's a huge lag time. So if we can get patients to come and enroll through the web portal, the data will be more timely. And then most importantly are the brief risk factor surveys that we have online that we really want patients to take the time to complete. And I'll go through some of the, actually all the risk factors that we have to date are in front of you here. And so there are 17 different risk factors, modules, and by design, these are meant to be quick, short modules for people to take. I've heard from a lot of you that, hey, you didn't answer, or you didn't ask this question or that question, or you need a module on this and that. And we agree. You know, we would ask you a million questions if we could, but by law, we're not allowed to overburden the American public. So regardless, we have launched 17 surveys, and many of these surveys, actually all of these surveys, are an attempt to get at what causes ALS. You can see occupational military history was mentioned. The thing about the military history module is that we are asking questions on what particular branch in the military did you serve in? Were you ever deployed to a wartime theater? And so not only will it help us see is, you know, military associated with getting ALS, but we can also actually drill down and see is there a stronger association with those in the Air Force versus Army versus the other branches. All of the surveys up here are ones that have been mentioned in the literature as having some kind of association with ALS. And so obviously military history is one that we're very interested in, smoking, alcohol, and you can kind of go through here and see the different survey topics. All of these surveys, except for one, is meant to be taken one time. And so when you enroll in the registry, it'll take you to this page where you can go through and take the surveys. I think it's important to note, you don't have to sit down all at one time and take these surveys. If you want to take one on one day and then come back the next day and take a couple more, then that's fine. I think if you sat down from start to finish, it would probably be about an hour and 15 minutes. So, you know, we would encourage you to take it at your leisure, but it's not a requirement to take them all at one time. The only one that is a module that's taken multiple times is the disease progression module. So obviously, this is a longitudinal module, and we want to see a person's disease progression over time. So maybe the first time they took this, they're mobile, they're able to talk, but as time goes on and what we know about ALS, you know, we want to see how quickly the disease progresses in people, and especially a large a large group of people. As of yesterday, we're up to about over 43,000 completed surveys, which is great. And you know, we appreciate not only the patients, but we appreciate the chapters out there who are pushing the registry and who are actually sitting down side by side with those patients that don't have a computer or maybe don't have the internet. We really appreciate that. But if there are people out there who have enrolled but haven't taken the time to take the surveys, if you could encourage them to take the surveys, the more data we have coming in, the more robust the data are going to be, and we're going to have a lot better sample size in terms of analyzing the data. I wanted to put a slide up here to talk about, we constantly get asked about how many people are in the registry. Well, that's not an easy question to answer, although I will answer it in a couple of slides, but because we have two different approaches, what you see here is the web portal enrollment. So we're really at about, this is for calendar year 2014, about 140, 150 new patients a month coming to enroll. And this is, like I mentioned, in large part because of the chapters and what you do every day. You can see there was a spike in August, and that was because of the Ice Bucket Challenge. So even though CDC, we're not getting any money from the Ice Bucket Challenge, we are getting people coming to our registry. We're capitalizing on the notoriety of ALS and the Ice Bucket Challenge. And so this is fantastic for us as well. So I want to talk about some of the results that are coming out. We are publishing a lot of new papers this year, and there are a couple that are already have been published, and I'll show you those. But the first thing I want to talk about is the first report that we released last summer. And so, as I mentioned, this report covers October 2010 through the end of 2011. In October, because that's when the registry was launched. Through the combined approach of the web portal and the national database approach, we identified over 12,000 people as having ALS. And if you look at it and you do the prevalence calculations, this equates out to about 3.9 cases of ALS per 100,000 people. ALS is more common in whites, males, non-Hispanics, and really people of older ages. Males had a higher prevalence than females, and that was across all data sources. The lowest number of cases were the ones in the 18 to 39 category. And really, these findings are consistent with what we see in other registries, namely the large European registries, ALS registries, and other small-scale studies that have been done across the U.S. I know that there has been concern from some people saying, whoa, 12,000, this is nowhere near the 30,000 that's been often quoted. And I think, my own personal feeling is when you look at the 30,000 number, no one knows where that number came from. And this is just a number that's been kind of perpetuated for years. And so one of the goals of the registry is to really hone in and get a true representation of what is the incidence and prevalence of this disease. But I do want to mention, this is the first year of data. This is what we consider baseline data. So as we continue to move forward, we're going to release more years of data, and we'll be able to use it for a number of different purposes. Obviously, for trends will be very helpful for us to see, is the trend of ALS going up? Is it decreasing? Is it staying the same? So this is a process. Okay, so just keep that in mind. If you look at the cases by data source, you can see here that about 16% of the cases came through the portal alone, so the web-based approach. But the lion's share of cases came from Medicare, Medicaid, and VA, and that's what we expected to see. And that's largely because of the Medicare eligibility for those who are diagnosed with ALS. So a lot of different cases, or most cases, will be coming through that channel. About 15% we found in the portal and the national database. So I just wanted to make you aware of how we're capturing these cases. All of these figures are on our website. I believe the ALS Association has the report on their website as well. And this is just a breakout of prevalence rates by age group. And you can see those in the 70 to 79 category had the highest prevalence rates, almost about 17%, or 17 per 100,000. And so this is not unexpected. I think it's important to show that if you look on the far left side, people at younger ages do get ALS, you know, and this is from 18 to 39. So, but the most people who get the disease tend to be in the upper ages. If you look at cases by sex, males have a higher percentage of cases versus females. Our ratio is about 1.56 males to every 1 female, and therefore the male prevalence rate is higher than the female prevalence rate. Why that is, again, there's a number of different hypotheses, whether it could be, you know, occupational related, some kind of exposure. We're not sure, but again, this is something that we're looking at through the registry, these types of differences. Why do males get it? Why do Caucasians tend to get it more than African Americans? And speaking of that, so the white prevalence rates were almost twice as much as the black prevalence rates. And we had to use these categories because this is how the data came to us. It wasn't broken out into further categories from Medicare and Medicaid. But again, I think this emphasizes that you could argue this is largely a Caucasian disease. Again, not sure why that's the case. Is there some kind of biological underpinning that makes it such? Again, this is why the registry is important for us to look at the data from a number of different standpoints. Getting back to the 12,000 number versus the 30,000 number. So the NIH did a paper several years back looking at how common are neurological diseases. And if you look at the highlighted portion here, for prevalence, we're right on target with what they projected. They projected about 12,000 cases per 100,000, or 12,000 cases in the U.S., which comes out to about 4 cases per 100,000. Incidence, and I'll talk about incidence in a few minutes, but we're right on target with incidence as well. So again, want to let people know that we're not that our findings, these aren't unrealistic findings, and I think this slide kind of illustrates that as well. This was a paper done by the Italians a couple years back, and these are the prevalence rates across the country. And if you look in the middle, the North America rates, there were a couple studies that came up with 3.2 per 100,000. One came up with 2.9 per 100,000 prevalence. So we are in the ballpark of where we think we should be. Now, if you look at Europe, though, it's a little different story. Some of these countries have higher prevalence rates of ALS. I personally think it's because of the population makeup. So in Europe, many countries are homogeneous, you know, whereas in America, we're a very, very diverse country. And so you factor in that, you know, through our findings that African Americans and Asians don't get ALS like Caucasians. that would tend to bring down the prevalence rates. So I wanted to put this slide up here to let people know that, we feel like we're in the ballpark of where we should be. But again, this is the first year of data as baseline data. And as we move forward, as we start to test the completeness of the registry, we'll be able to kind of hone in on more precise estimates. Next report. Our next report is going to be what I would consider kind of all-encompassing in terms of epidemiology. So we're going to include prevalence, mortality, and selective incidence. And you can see here prevalence will pick up from the last report. So the last report largely covered calendar year 11. So we'll be looking at calendar year 12 and 13. We're going to be looking at mortality as well. One of the things that I think that we're going to do is to put up a prevalence map, so essentially a heat map, so that we can see where do the cases scatter in the country. Is it higher over here versus over here? If so, what's the reason? So I think that these are good ways to use the data, but again, the more people who enroll, the better the data will be. So if you can just keep that in mind. I know that there are folks out there with the disease for whatever reason may not want to enroll. That's fine. That's their decision. We can't force people to enroll. But what we want done is at least give the people the opportunity to know that the registry is there so that they can enroll. So I want to switch gears and talk a little bit about some of the state and metro-based studies that we have concluded and that we're publishing and are about to publish. If you'll remember, we launched the state and metro-based initiative a couple years back for a number of different reasons. The big reason is we want to test the completeness of the registry, and we're doing that because the state and metro approach, it's an active surveillance approach. So in other words, we're going out to these various catchment areas and actually contacting every neurologist in these areas to see are they treating patients. If so, we're having them fill out abstraction form with name, some information so that we can bring back to the registry and actually cross-reference that data with what's in the registry. And then another reason that we're doing this is to generate area-specific rates. What's the ALS incidence in Philly versus San Francisco? So this hasn't really been done across the U.S. As I mentioned, there are a couple studies, but now we're really digging deep and trying to quantify the epi findings for specific areas. And so we launched this in 3 states and 8 metropolitan areas. We focused on data collected from 2009 to 2011. We also looked at prevalence in these particular state and metro areas. And if you look at the combined prevalence rate, it's pretty much right on with what we see on the national level. We came up with 3.8 cases per 100,000 population, and that was based on about 6,000 ALS cases in these different catchment areas. Incidence, so we're able to look at incidence through the state and metro initiative. And again, prevalence is new cases plus old cases over a given time. Incidence is new cases over a given time. So what we see for incidence rates is about 1.5 cases per 100,000, and that's based on about 4,000 new incident cases diagnosed from 2009 to 2011. Again, people in this cohort, in the state and metro cohort, tended to be white, male, non-Hispanic, and in the 50 to 79-year-old age range. Median age at diagnosis was about 64 years. Again, we're seeing males with higher rates than females. In this largely mirrors what we found, 1.5 males to 1 female. And we're also able to look at familial ALS in this cohort. And what we came up with is about 4% of the people in the state and metro areas had a family member with ALS. Now, if you look at if you step back and look at the general findings that 5 to 10% of cases are familial, and the rest, 90%, are sporadic. This pretty much bears that out. But again, this is just one metric that we're looking at. Dementia. We also looked at dementia, which was mentioned this morning by Lucy. Dementia was reported for 7% of the cases. I kind of mentioned this earlier, but we do see significant racial and ethnic differences in incidence. And we just had a paper published not too long ago that details this, but largely whites were statistically higher than blacks and Asians. And then non-Hispanics were significantly higher than Hispanics. And again, this is consistent with what you see in the literature and what's out there with other ALS registries. Just wanted to put, and again, all of this data is on our website. This is the state and metro prevalence combined. So for the metropolitan areas, it was about 4 per 100,000. It was lower in the states, but a combined estimate of about 3.8 per 100,000. If you look at the incidence rates, and I see that one of my values didn't come through, but again, incidence is about 1.5 if you combine it. Some areas had higher incidence rates than other areas. Again, it's possible it could be due to reporting, but it's also possible that it could be due to the racial makeup of these particular areas. Maybe some groups have better health care than other groups. But again, this kind of sets the benchmark and the threshold for incidence and prevalence in the U.S., specifically within these 11 catchment areas. If you look at the worldwide ALS incidence, again, we are pretty much where we thought we would be combined for the state and metro, about 1.5 per 100,000 cases, and that ranged from 1.3 to 2.1. If you look at in the middle, again, in the North America row, it looks like it ranges from 1.7 to 2.2. So again, we're in the ballpark of what we expect it to be. Just want to mention, you can go to our website to download any of these papers that we published. What we're starting to do is to buy open access to these journals so that people aren't stuck behind a firewall or a paywall where you have to pay money. We don't want that. So we're buying access to these articles. And so you can come to our website and click on it and download the paper and read it at your leisure. So let me switch gears here and just make a point to say that the registry is not only about quantifying incidence and prevalence and mortality. I mean, that's important. The epidemiology of ALS is important. But we also do a lot of other beneficial things. One of the things that we're doing is helping patients link up with clinical trials or epidemiologic studies. We know that patient recruitment for research can be difficult. Just going to clinicaltrials.gov and trying to sort through that is a chore in and of itself to try to make sense of that. But we know a very high percentage of PALs who are enrolled in our registry want to take part in some kind of research. And so what we've done is set up a platform so that when a new person enrolls, all they do is click a box saying, yes, please notify me of any studies that I'm eligible for. And we will notify PALs of studies where they meet the eligibility requirement. Now, We don't necessarily want PALS to solely rely on this. You know, if you want to go to clinicaltrials.gov, great. If you want to go to NEALS, great. This is just another platform to help us link PALS with researchers. And so far, we've had 16 different researchers around the country use our registry to recruit patients. And we've sent out over 51,000 emails to PALS. And again, it's not 51,000 different or unique PALS. Many of these studies, the researchers wanted us to push it out nationwide. They didn't necessarily have a criteria, but others maybe wanted to focus only on males or maybe those in the military. So depending on what criteria the researchers were looking for, we could subset the criteria and push the emails out that way. But many of these are clinical trials. Others are research questions that need to be answered. We just got one from Australia. That's the bottom line one there, University of Sydney. We just sent that out last week. So again, if you get an email from us, you're not obligated to take it, but if you're interested, I would encourage you to take part in these studies. I do want to mention that ATSDR, CDC, we're not affiliated with these studies. So we're just kind of the middlemen and women linking people together. So we have no stake financially one way or the other in these studies, but we do want to use the registry to promote it for research purposes. Research funding. Again, we don't have the deep ice bucket challenge buckets of money, but we do have some money that we can use for research. And so we have been funding research proposals for the last couple years. Ours focus specifically on the etiology aspect. You know, someone asked a question, well, why aren't you looking at research specific to etiology? Well, this is what the research is that we fund, and what are the risk factors associated. And, you know, anything that we glean from these findings that we fund, we can turn around and create a new survey module to help us test or refute or validate those findings. So again, if someone comes up with a novel finding of say statins or something like that hasn't really been mentioned so much in the literature, we could put together a risk factor module, launch it, and then have patients come in and answer questions. We did just post a new announcement in January. We anticipate making 2 to 3 more awards by summer's end. And so right now we are up to 8 research proposals that we have funded. Many of these investigators, you probably recognize the names. So we're very happy to be able to use what limited funds we do have specifically for research for etiologic and risk factor purposes. And then I'm going to close on this. This is an initiative that we're very excited about. So for the last 4 years, we have been executing a biorepository pilot study. And we know that biospecimens are very important for research. And so what we did was we tested the feasibility of folding a biorepository into the National ALS Registry. So this began in September 2011, and it will conclude this September. And for the last 4 years, we have collected hundreds, actually 600 or so in-home specimens. And you can see up top blood, hair, urine, nails. And then we've also collected postmortem specimens, and we're up to 12 postmortem collections to date. And you can see here, Lucy talked about it, we've also isolated fibroblasts from 4 PALs. And so what does this mean? So the future of the biorepository the preliminary results indicate that this biorepository is feasible and that it's warranted. And again, let me just state that CDC, we didn't sit around in the room and say, let's launch a biorepository. Over the last 4 years, we have brought in experts from around the country, experts in ALS, experts in biorepositories, and long story short, the overwhelming consensus was such an initiative will be tremendous in terms of the scientific impact for advancing the ALS science. And so we're happy to say that we are going to be launching the National ALS Biorepository this fall. And we've gotten some questions from people, well, how is this going to differ from the other biorepositories out there? And again, it wasn't our intention to try to hone in on someone's territory or be duplicative, but this biorepository will significantly differ from those others that are out there. I guess the biggest way is we will be able to link the biospecimens with the epidemiologic data that we're collecting through the registry. So in other words, if someone wants to contribute blood or hair or nails or whatever, we would be able to also link that with their survey data. So we could tell you this blood came from a plumber who lives in Idaho who was in the military. Whereas some of the other biorepositories out there right now, you know that you've got blood and maybe this person's male, female, but this will have a very rich data, epidemiologic data linked with the biospecimens. And so that's one of the biggest differences. Also, this will be a nationally representative biorepository. So in other words, we wouldn't just be collecting samples from large ALS referral centers. We want to capture the people out in rural Idaho or Montana who have ALS and want to contribute. And maybe they have a hard time because the closest referral center is hundreds of miles away. So this is also going to be user-friendly to PALS. So one of the big things that we tested over the last 4 years is sending out phlebotomists to patients' homes to actually do the in-home collection versus having PALS get up, get dressed, get in the van, the whole production going to a referral center, which is not easy, as you very well know. So this would be the approach that we'll start using in the fall, recruiting phlebotomists to go out and do the in-home collection. And again, the collections that we get are specific for a biorepository, and these are not samples that are just left over and then we cobble them together. You know, these are collected for specific reasons. And in theory, all these pre- and post-mortem samples would be housed together in one biorepository that would be linked to the National ALS Registry. I want to mention one thing, too, that I don't have on this slide, but it's been raised before. We are actively pursuing the global unique identifier, the global ID. We think that it's very important, especially now that we're going to bring the biorepository online, to be able to link the samples or the epi data with other research that's going on around the country or around the world. And so right now we are working with our IRB to get approval for that. And then the next step would be to approach the Office of Management and Budget to get their approval to let us do this. And the reason OMB has to be consulted and get approval from them is because we would be collecting additional information that's not collected through the registry to generate one of these global unique identifiers. But we are moving that direction. We think it'll be very helpful for us to connect with other researchers around the country and around the world. So just want to conclude that this is the first and only population-based registry in the country. We're fulfilling the congressional mandate the best we can, looking at collecting incidence and prevalence, demographics, risk factors. The registry is also being used for recruitment purposes to help bring PALs into research around the country. We are providing funds to researchers around the country to help us look at etiological factors. Again, I mentioned the full-scale biorepository. We're anticipating launching that this fall, and I believe someone raised the question earlier about where they could donate some kind of sample. We're going to have clear instructions on our website about how to do this. You know, whether you want to donate a living sample or, you know, you want to donate your body for a post-mortem sample. But we do want to give people the opportunity, if you want to be a part of a biorepository, that you would have that opportunity to contribute your specimen, whether it's through us or another biorepository. Just know that you would have that opportunity. And then just, you know, again, at the end of the day, we're trying to really build the evidence to describe how ALS is impacting individuals, populations, family members, and we're trying to tell the story, trying to tell your story to really advance the science. And I think that was my last slide. Again, someone mentioned earlier, this is not a one-group initiative. This is everybody, okay? So we can't do it without the ALS Association. We can't do it without family members, researchers. We got to have people to help us tell the story of the registry and why it's critical for PALs to enroll in the registry. And with that, I would be happy to take any questions. And again, if you don't want to ask a question in this forum, feel free to stop by the registry booth out here. Thanks.
So, Kevin, in the pilot study for the biorepository, you actually had medical professionals going out to the people with ALS in some cases. Are those talked about for the future?
Right. So those were the phlebotomists that I mentioned. Trained phlebotomists going out collecting biospecimens. We use the Boston VA to do our postmortem harvesting and collection. So yes, all of these. And the thing I mentioned is this: there's not a cost to any patient. You know, we've heard that there could be some costs associated with other initiatives outside of what we're doing. If a person is taking the time to donate their biological specimens, we're not going to charge them. I mean, they're doing us a favor by helping us build this biobank. So keep that in mind. This would be free of charge, including the postmortem harvesting.
Brian? Hello? Woo!
I don't know where I'm looking. Oh, back here?
Right.
Oh, hey.
As far away from you as I can get, obviously. I have participated in this since I was diagnosed in 2013. Clearly, it's a self-selecting thing because, you know, every PAL isn't going to do it.
Right.
But one of the very interesting things about the occurrence in my city, we are a city of less than 10,000 people, and there are currently 4, and 2 previously have died of ALS. So we skew your numbers tremendously, but no one's reporting it because it's self-selecting.
So that's a good point. One of the things the registry will be able to look at is, you know, what's the background ALS in a given area, and are we seeing what we consider excesses in a given area? If so, why? And so we'll be able to use the registry data that way. The map, the heat map that I mentioned earlier, once we're able to put this in a map, I think that will be very informative as well, and maybe your area will show up, you know, on the high side. I'm not sure, but at least we'll be able to use the data for those purposes.
Am I next?
I guess.
Okay. I'm Marlon Seymour. I'm with the Central and Southern Ohio chapter, and our area covers Columbus. The 3 metro areas are Columbus, Dayton, Cincinnati, and then we also cover less populated areas east of Columbus and southeast. And one of the things that we found as a challenge is really convincing our patients that this is very important to participate in. I think we've had fairly good participation, but one of the things we've found is that patients will register, but they won't fill all the surveys out.
Right.
We have attempted to try to get volunteers at our clinics to help patients fill the surveys and register there, but the clinic visit typically is so long that it's exhausting for them.
Right.
So we've started a new program. We've just started a new program where we're recruiting volunteers to actually work with our patients, to sit with them, get them registered, help them fill the surveys out. One of the things I was thinking of as I was sitting here this morning listening to you was actually beginning to do support group meetings, maybe at all of our support groups, have one support group just focused on presenting about the registry.
Right.
Would you be willing to share your slides?
Absolutely.
So that we could do
Yep.
that?
Yep. I think that's a great idea. You know, whether a person enrolls at a clinic or whether they enroll at a chapter support group or whether they, enroll with a family member, we don't care. We just want people to enroll or at least have the opportunity to enroll and to know why they're enrolling and why this initiative is very important. But I think that's fantastic what you're doing, and that's a great idea.
Over here.
My name's Brad Blaha from the Minneapolis chapter. When you guys combine this up, as I'm already signed up for that, you don't have to redo all the surveys and stuff all over again, do you?
No, once you take the survey modules, you're done.
So
Except
all
for
that's
the
going to transfer over when you guys take
well,
over,
this so
right?
the biorepository is just a separate initiative to collect biological specimens. So we'll still have the base, the registry that collects, the epidemiologic data. So even though we're launching a new initiative, that's not going to impact your surveys.
Okay.
Yep.
Thank you.
Hi.
This
Over here.
lady's been waiting.
I'm actually in the pilot story and committed to having was probably the simplest thing I've done
Right.
since I've had this disease, and I think more studies and trials should be trying to utilize things like that, so thank you. In terms of the data, when you look at the metro numbers, you see cities like Atlanta, Baltimore, Detroit, Chicago in those calculations that have large African American populations, much larger than the national average.
Right. So
Yet we still see a higher prevalence number
right.
than the state and the national numbers, which
Right.
suggests to me perhaps at the metro level it's easier to actually find cases.
Right.
And it's more a matter of us missing cases in the 3.9 calculations.
Right. So a couple things. Thank you for contributing your biospecimen, and I'm glad that you think it's easy because, again, that's the selling point. Pals don't have to go to a referral center. Let us come to you and let us, collect your specimens if you're interested. As far as the state and the metro, one of the main reasons that we did this and the way that we picked the 11 catchment areas is we picked sites, these 11 sites that were overrepresentative of minorities. So we picked Atlanta, Detroit for African Americans, Texas, because we wanted to see, and we've read in the literature for years and years, this is largely a white disease. Well, we wanted to see, is this really largely a white disease? And while the data is still coming out and it's going to be published, we're still seeing that Caucasians have twice the rates as Asians and African Americans. Again, not sure why, but it's something that I think we need to look at. How do I explain the prevalence? Oh, yeah. I think we're gonna have to wait and see what it says in the paper. I mean, I can't give you the reason behind that. I don't know. I wasn't one of the co-authors, but we're looking at that, and that's a good point. I don't know. But the state and metro initiative has been very critical to provide sorely needed epidemiologic data down at the kind of the granular level. So it's very important for us, and especially when we cross-reference that data with the national data. Yes, ma'am.
Hi, I'm Jane. Hello?
Hi.
I'm Jane Williamson from the Massachusetts chapter. I noticed in your data there was a big drop-off in completed risk factor surveys from 2010 when they were in about
Right.
the 4,000s
Right.
to present day or even
Right.
2013. Can you hypothesize on that?
So what I think is happening is if you look at it, demographics, that's the first module that you take, and as you go further down, if you take them in order, it just trails off. You know, most people, when they come in, they'll click survey 1 and they'll take that. And then maybe they'll take the second or third one, and then maybe they'll stop and they won't come back for a while, if at all, to come back and finish the other surveys. So in other words, I think if we had some of the surveys that are not well completed, if we moved them up top and switched the orders around, we might see, you know, more people taking those surveys. But also some of the surveys are more in depth than others. So for example, the military one, easy yes, no, were you ever in the military? If no, you're done, move on to the next one. You know, for the one that has the family history, if you have family history of ALS, that can take you a while to go through and list. My brother had it, and he was this age, and so I think that also plays a part in it as well. But that's where I was coming from. I think it's critical if a person wants to complete these surveys, we don't expect you to sit down and do it all at one time. You know, if maybe you, like I said, take it one day, put a note down saying, hey, I'll come back in a couple days, I'll take this one. I think, you know, we can get the numbers up. There's a couple right here.
I just wanted to know what the date of your next report would be.
So right now we're anticipating later this year. I can't give you an exact date. It's a little challenging because as we move into prevalence from 2012 and 2013, we have to run that data through the National Death Index to separate how many cases have died. And that's a process as well. That's something that we didn't have to do through the first report. And so it puts us a little behind. But we are trying to get the data out as fast as we can. But in the meantime, we've got a lot of data coming out through the state and metros. And that's that web page that I showed you. You can go and read all of these new papers that were published.
Awesome, thank you.
Yes, ma'am, back here.
Yay, he saw me. Okay, my question is about data collection. So even though ALS patients are eligible for Medicare or for disability, not all of them choose to go on disability or enroll in Medicare or Medicaid.
Right.
So is CMS providing data only for patients who are in Medicare and Medicaid, or are they providing data from the private healthcare sector?
No, and this is one of the limitations. So if you think about it, how many different HMOs are there around the country? Probably hundreds. We know that there are some cases that probably get all their care through a private HMO. We're missing those people. We have no way to have some kind of agreement with 100 different HMOs. Plus, not every HMO is going to want to contribute data to the federal government. So that's been very challenging, but that's where, I'd say if we can get these people, if they go through their HMO, if we can get them to come through the web portal approach and answer the questions, we can capture them that way. But you're right. I mean, that's a segment of people that we would be missing.
So are there any efforts in the future to try to connect with the private sector, given that we're doing a lot?
It's something that we've got in the back of our mind, but we've just got to get a handle on how we would do that, given that there are so many different providers out there. But that's a good point. Yes, sir.
I've got,
Oh, go ahead. Sorry, I can't see with the light.
No, that's okay. A couple of questions. Bruce McClure from Albuquerque. One, none of our neurologists that we've been associated with have ever mentioned the registry, and I'm wondering what kind of outreach you guys are working on with.
So that's a very good point. So myself, Paul, Tom, I think we're on the road so much, and not only to try to get in front of patients, but we have to get in front of neurologists, and so that's why we hit all the major conferences. But again, this is a collaborative effort. So if the ALS Association runs a large referral clinic, we really want to rely upon the association to educate their neurologists and their staff to be a mouthpiece for the registry. Same with MDA, same with other organizations that operate clinics. But you're absolutely right. Neurologists are a critical mouthpiece for us. And patients, I think, tend to rely heavily on what their neurologist tells them to do. And so you're absolutely right. So we're trying our best to get out in front of these neurologists and healthcare providers, and I think the ALS Association is too. But if you've got ideas on how we do this, one of the things that we did several years back is we got the mailing list from the American Academy of Neurology. And so we got the contact list of all the neurologists around the country, and we did an email blast to them. The problem with that, it was kind of like a shotgun approach. Not all these people, not all these neurologists deal with ALS patients. Maybe their focus is MS or something else. And so we got to get a better handle on how we could do this in a systematic approach. But I think the major starting point is let's start with the ALS Association clinics, let's start with the MDA clinics, because combined those represent the biggest portion of clinics around the country.
Thank you. I have one more quick question.
Okay.
Is there a methodology in the registry to enroll people post-mortem if they had never registered before?
Yeah, so
I realize the data may be...
That's a question that we get often. The problem with it is it's not that we don't want that data, but the questions that we ask are pretty specific. And so we don't want a person go in and try to answer questions on behalf of that patient and enter in data that's not correct. So there's a trade-off. Yeah, we're missing that data, but we'd rather the data we have be correct. So again, that speaks to, if you know a person with ALS right now, have them enroll so that we don't have to face that challenge down the road. When a person dies, then trying to capture their information.
Question from the far left. Over here. For those of us who've already participated in a pilot study, when you launch in fall, do our specimens get passed over?
Great question. Great question. So, yes. So they're going to transfer over into the new biorepository. And so those samples will be there. We're setting up a platform right now where researchers can come in, fill out a questionnaire, upload it to our website. We'll evaluate it in terms of scientific validity. Basically, why do you want this specimen? What are you doing? And so we're getting the platform set up for that. But yes, your specimens will be transferred over, and this will be the kind of the base that we start on. So we already have 600 specimens plus 12 post-mortem, so we're already off and running right now once we launch this. So thank you for contributing. So I think that's it, but I do appreciate your time, and if you can help us enroll people.
We're out of time, so we'll have to
Well,
come see Kevin at the booth.
So we're out here, but thank you for your time. I appreciate it. Good luck tomorrow.